My name is Bryan Clardy. I'm an associate professor of family and community medicine for UAMS at the Western Campus in Fort Smith, Arkansas. I also serve as the Sebastian County Health Officer, a position through the State Board of Health and the Department of Health. People don't realize those actually aren't the same entity, but they do talk together a lot. And in that role, I have been asked to participate in a local opioid task force, and have been doing so since about 2018. I will go ahead and give you one caveat. I have shamelessly stolen about half of my slides from Kirk Lane's presentations over the years. He's our former drug director and now is taking a job in private industry where he's still working as a consultant for the state regarding drug policy. And we appreciate all of his contributions to this effort as well. If at any time there's issues with the presentation, please let me know through the chat and we will get them rectified immediately. So this is our community response. And one of the areas where we as family physicians do a poor job, and this has actually been reported in the literature, is we don't do a good job with advocacy for our specialty and community engagement frequently. And I think what happens is we're such a busy specialty, we end up just putting our head down and just trying to get through clinic and get our patients seen and take care of them. But the extraneous stuff is hard to address at times. Having said that, the opioid epidemic and the opioid crisis has impacted all of us. And it changes how we practice medicine, and it certainly changed the demographics of our patient populations. I have no financial relationships to disclose. I'm going to try and limit where I reference to branded medications. The only one we're going to talk about is naloxone hydrochloride or Narcan. If I say Narcan, just assume I mean naloxone hydrochloride. But I have no dog in that particular pharmaceutical fight. So I want to start off with, this is our former sheriff, Sheriff Hollenbeck. And this is something that's been said in a lot of venues about we can't arrest our way out of this problem. And he was our sheriff from 2010 to 2018. And he was succeeded by Hobie Runyon, who's our current sheriff. And he basically said what he said. It's interesting. One of the things I think is very important, at least in our community, is the appropriate and peaceful transfer of power between offices. And Sheriff Hollenbeck was a Democrat and Hobie's a Republican, but they got along great, and they've got different political philosophies, but the continuity of the office and the way it serves the population has been maintained, and I think that's been great for the community. So I want to start with our age-adjusted overdose death rate. This is 2010 to 2018. So I'm going to be going over some of the historical data in order to give you some context for the current data, or at least the current data I've had access to. I will tell you this as a caveat: COVID-19 has made access to current data difficult at best. So, and I'm going to focus mostly on Sebastian County, but it does apply across the state in a lot of ways, especially since Sebastian County initially was at parity with the average prescribing habits in the state. And at this point, our age-adjusted overdose death rate per 100,000 was about 10 to 15. And that's probably very much underreported due to differences in how each county reports based on their coroners. One of the things that Gene Shelby did when he was our representative from Hot Springs area, Garland County, he did put forth a bill to standardize reporting for a lot of different death conditions for the local county coroners, and that's made reporting a lot better. Still not perfect, but it is better. And anyone that's logged into E-Rave will understand when I say it's not 100% fixed, but we're getting there. In 2020, here's our overdose death rate, and it's gone up. So we now have more than 16 to 20. And again, this is going to be underreported. And this is Department of Health vital statistics. But this kind of shows you the general map. Some of these counties are reporting 0 to 5. That again goes back to the, are we having issues with how these things are reported? And also you look at transport as well. Little River County probably gets transported to Miller County. So where does the death occur? Does it occur in Little River, or does it occur in Miller County? And those kind of issues are, again, reporting that makes it harder to track these statistics. One of my favorite expressions that I use with our residents all the time, especially when talking about quality improvement, is that what gets measured gets improved. And so if you don't have good data, it's very hard to address it. 2018, this is the average prescribing rate. And this is a whole number that is the number of prescriptions per individual or per 100 individuals in that county for active Schedule 2 and 3 medications or narcotics and benzodiazepines. You'll notice Sebastian County had 102.1 prescriptions for every 100 people. So there was more prescriptions than there were people in our county. And this is in 2018. And the overall rate for Arkansas at that time was 102.1 as well. So we were at parity with the state average. Now you start looking at other counties like Poinsett, Ouachita, Lawrence, you're seeing rates as high as in Poinsett 164.7 prescriptions per 100 people. So this is a tremendous problem with overprescribing at this time. And this is basically pre-fentanyl, before we really started getting a good handle on some of this. 2020, the overall rate for Arkansas dropped to 86.3 prescriptions per 100 persons, and Sebastian County got below the state average to 83.1 at that time. And that's something we're pretty proud of. We feel like we did some good work with our task force up here. And the overall rate for the state dropped as well. And then as of 2021, we got down to 71.7 for Sebastian County. So we've made a tremendous impact locally. And I think a lot of that has to do with education. One of the things that I've been doing annually for the last 3 years is an opioid update for local prescribers that counts as their 1 hour of mandatory CME for prescribing. And some of the recommendations I've made, I think, have been followed and have made an impact. This is our rate per 100 persons again, and this is CDC data versus the United States, and then we also have the PDMP data as well. So the CDC data is a little underreported once we start getting the PDMP. I think that's a little more accurate in terms of our data, but you'll notice in 2015 when we started tracking our PDMP data, that was at parity with CDC, and that followed for another year, and then we start seeing a pretty steep decline. And so I think that again demonstrates the effectiveness of some of the legislative interventions we've had. For example, the PDMP program, which has helped reduce doctor shopping quite a bit, has been a major has had a major impact in prescribing habits and in number of prescriptions written per patient. So I think that's been an improvement as well. Now, unfortunately, starting 2019, 2020, you start seeing fentanyl coming in as a replacement drug, and this is something that's been noticed in other states as well in the last 10 years or so, that when a state cracks down on overprescribing, that illicit drugs then will come in to fill that addiction void. So just reducing your overprescribing doesn't necessarily fix your problem. You have to prevent the problem in the first place. Neonatal abstinence syndrome, which is our babies that are born that have got a withdrawal syndrome that we treat, is responsible for a huge amount of the burden of our cost burden for Medicaid and services in the United States and in Arkansas. And you can see here it was going up. We had 2017, we had 5 cases per 1,000 births. I can tell you locally, we take care of a number of those babies in our nursery and have the aftercare. We had one child that was in there for 2 months withdrawing. It was, it's just an incredible issue there. However, that seems to be finally improving. And as of 2019, and unfortunately I don't have any more current data there, we started seeing a decline. So that's been, it's been good. And that's a decline of almost 40%. And that's pretty, that makes me pretty happy, especially having seen these kids in the nursery. So what's the formula to get to some of these successes? So you have some key players, and you need someone with authority locally. In our case, it started off with Sheriff Hollenbeck, that transitioned to Sheriff Runyon later that year. And they have political connections. They've got law enforcement connections. They've got connections to, that are local, state, and federal, which is all of our players in the county, and that includes DEA. We did have one issue with our DEA jurisdictions here. In the Oklahoma jurisdiction and the Arkansas jurisdiction were 2 separate divisions for DEA. They didn't cross the border, and so that did cause some issues with the overprescribing that was coming in from Oklahoma. Sheriff Hollenbeck also had connections with the school system. His wife was a principal in one of the private schools, and then he ultimately transitioned to a position with the Fort Smith Public Schools and established a new police department for resource officers in the Fort Smith Public Schools. Also has connections with the courts and corrections, clearly. Some of you know that I do a lot of disaster medicine. You hear me talk about incidents and incident command, that sort of thing. And he was our incident commander for the local opioid crisis. So served as our liaison to all the higher ups and then set all the goals and priorities for the task force and what we were trying to accomplish. Sheriff Runyon has been reelected recently, continues to have his political connections, law enforcement connections, all of our players in Sebastian County. And then Chief Hollenbeck then joins the Fort Smith Public Schools, as I mentioned, and established a separate police force of the school system. And one of the first things he did was get his Fort Smith Public Schools Police Department trained for naloxone and had kits deployed. So this is the intranasal Narcan that's been pushed by the Criminal Justice Institute for law enforcement use and has been deployed in a number of jurisdictions. So the first meeting I went to was February 15th in 2018, and these are kind of some of my basic notes here. Mercy Hospital hosted it, which is our hospital across town. And my notes from that day, my first question was data. Where is it coming from? Who's prescribing? What's being considered? Like what are we doing? At that point in time, I had read about heroin being a substitution drug that came into these communities after there was a quote unquote crackdown. And so my concern was, is that coming? What are the ramifications there? What was the PDMP effect upon prescribing at that point in time? And just to explain, the PDMP is the Prescription Drug Monitoring Program, which all prescribers are required to check every time they start a new or renew a prescription for a controlled substance in the state of Arkansas. But what was the effect upon prescribing at that point? We didn't know. This was 2018. Turns out it was a profound effect. The Oklahoma issues, we had several clinics across the border in a neighboring community that's about 10 minutes away from Fort Smith that had the notoriety of overprescribing as quote unquote pain clinics as well, and also were prescribing methadone for chronic pain, which was its own separate issue. What was the cost of Suboxone we were talking about for medical assisted therapy for opioid use disorder, and how are we going to get it paid for, that sort of thing? And did we even have a budget? And did we have any authority? And we really didn't. So at the time we had Sheriff Hollenbeck there, we had a local group called Restore Hope, which worked with families who were impacted by the opioid crisis. Mercy, Sparks at that time, which was then became Baptist. We had a representation from the Department of Health there, ARCOM, which is our local College of Osteopathic Medicine, County Medical Society, the Dental Society, UMS West Residency Program, and then we had some support staff. You'll notice I've got that in red. That's probably the most important thing, because all the people that are listed here, or all the representatives that are listed here, are all busy, and this is basically extracurricular activities for them. So you need to have someone that's going to kind of wrangle everybody. 2018 continued. We had a meeting with Director Lane in April, and we were able to get the CJI grant for Narcan for basically our entire county, which included 4 different jurisdictions for the police at that time. And so I was able to sign off on that. You needed a prescriber that was willing to sign off on it for that grant. And I did so, and those kits got deployed. So that summer, we then had our first local summit. This was organized for a multidisciplinary audience, but it was also organized for an audience that would include members of the lay public. This did fulfill a requirement for community engagement, and this is actually a summit we have repeated annually every year since, including one year where we had to do a virtual summit for COVID reasons. We were able to get our law enforcement officer Narcan grant in place, and we had a resource fair as well, where we started sharing information. One of the major features of our task force, and we do meet monthly at 7 in the morning, which for some reason all meetings happen at 7 in the morning. and we basically share information. That's our biggest thing, and problems, frustrations, concerns with our particular domains. And then frequently someone will pop up across the room and say, oh, I have a solution to that, or we're already dealing with that. And then you connect and you just share information. And that's been a lot of what we've been able to accomplish there, is just with the sharing of information. And that resource fair was similar to that, except we were trying to share information with the community. We had a panel discussion with the community, took questions, answered the concerns that the community had regarding what we were trying to accomplish. And then we were also able to get the Narcan expanded into all secondary and high schools. So that got us into the then junior highs, now middle schools and high schools in the area. Here's Kirk Lane, and Sheriff Hollenbeck is at our first summit, and he was discussing statistics regarding opioid prescription and abuse in Sebastian County. And this was June 20th, 2018, and this was hosted at University of Arkansas for Fort Smith. Again, everyone's time and facilities were donated to the cause, as we didn't really have a budget. Cheryl May, who's the director of the Criminal Justice Institute for Arkansas, talks about the more that's there, could even say one of our officers live or one of our first responders live. And that actually has come to fruition. We had 2 deputies in the jail recently that had to be resuscitated with Narcan after an altercation with an inmate, and they had an exposure. And there's a lot of misinformation on the internet going around about whether or not dermal and inhaled exposure is going to be a problem with fentanyl. And it is definitely. And we've, like I said, we've had deputies that have had to be resuscitated with Narcan after encounters with detainees at the detention center. At that time, Sebastian County had some of the highest numbers for opioid prescription and abuse in Arkansas. And in 2016, CDC, had reported we had suffered 25 drug overdose deaths at that time. In the state of Arkansas in 2018, there were 104 naloxone saves on people aged 16 to 62 in the state. And that was something that Kirk Lane had reported to us. We had in Crawford County, we had a sheriff's deputy who administered Narcan to a man who was unresponsive after injecting a substance in his vehicle. This is all stuff. This is older news because this now happens all the time. But at the time, we were pretty impressed with that, that we had that saved. Other activities in 2018, we supported grand rounds at both hospitals regarding opioid prescribing and MAT. Supported outside speakers for Project Matriarch, which is sponsored by UAMS and the Department of Psychiatry, as a model. Was actually modeled, I think, after the New Mexico project for hepatitis C treatment, but it was then moved over to MAT in order to provide professional and academic support for people who were prescribing MAT in the community, and to bring them up to speed on current guidelines, and to provide consultative services in areas where you had basically a psychiatric desert. We're one of those. We have very little in the way of psychiatric care in this area. We pushed the Don't Run, Call 911 information campaign. This was a law that basically said even if you're involved with the drugs of abuse, and your companion has an overdose, you won't be arrested or held liable for whatever you were doing, as long as you called 911. And that was a campaign we pushed out. That was an effort to increase survival and to decrease our response times for overdoses. We then encouraged co-prescribing of Narcan through the medical society and with resident education. Now, of course, co-prescribing of Narcan is mandatory. I will say one of the things I do like about EPIC is that it requires you to prescribe Narcan in accordance with state laws and best practices whenever prescribing a new prescription, or if you have to do an annual renewal. And then we had our summit in 2018, as we already talked about. This is, again, the Don't Run, Call 911 campaign, and this was CJI, SAMHSA, and then Department of Health as well, who all sponsored that as a law, and that's for the state of Arkansas. And we were just putting these posters up like in the bathrooms at the high school in an effort to educate. And then we also had some billboards around town that were that had this up as well. So here's where it really comes down to, or the multidisciplinary domains. And the idea was that the more people we could prevent from becoming addicted to opioids, the fewer people we would have to worry about treatment or entanglements with law enforcement or emergency care down the line. And so prevention, one of the big ones was to reduce prescriptions and reduce volume of opioids in the community. And then we wanted to prevent illegitimate use, and then we wanted to intercept unused prescriptions. So that was kind of our prevention angle. As far as education, we were looking at everybody, children, patients, prescribers, the community, residents, students. We now have 3 different residencies in this town, and we have a whole medical school. And so there's a lot of opportunity to start educating regarding responsible opioid practices early in those professionals' careers. As far as emergency care, we have our law enforcement officers, our emergency rooms, our EMS, our first responders, and lay members of the community. As far as law enforcement, we needed to get them educated for overdose treatment. They were going to be responsible for interdiction. They would address the diversion issues. And then we also have a drug court in Sebastian County, which has been very, very effective in reducing recidivism. And I wish I had the statistics in front of me, but it takes it from like 40% to about 5%. It's really an impressive result. And then alternative sentencing as well for first offenders and nonviolent offenders. Treatment, we wanted to see about developing more inpatient options and then outpatient options, especially with MAT. And then at the time we were looking at DEAX providers. Of course, as of this last year, that requirement's been waived, although the training is still very valuable. It's an 8-hour set of training that's available online. And I recommend anyone interested in doing MAT go through that training. And then Project Matriarch, sponsored by the Department of Psychiatry. And this is kind of how we looked at it. It was like, each person had their own had their own domain to work with, and then we just communicate and try to get everybody together and share information. We had a legislative domain as well, and that included things like insurance coverage for Narcan, which initially was not covered, and also for buprenorphine. We talked about harm reduction and what we could do there, and try to get support for needle exchange programs. Currently not legal in Arkansas, but it's not specifically codified, and usually it's prosecuted under the drug paraphernalia laws, but it's not specifically listed in the Arkansas Code. Interestingly enough, 80% of participants in needle exchange programs eventually seek treatment and has a demonstrated reduction in HIV and hepatitis transmission. And I would go ahead and add as a comma to that sentence, methicillin-resistant Staph aureus, something else that we have to deal with a lot, inpatient, that costs the system quite a bit of money as well. As far as the prescription drug monitoring program, that was a legislative maneuver that's reduced significantly the amount of prescribing we've been doing. State Medical Board now has mandatory CME for all licenses, which again, I hope that helps as well, since I participate in that. The medical marijuana, that evidence is kind of mixed and unclear. The initial evidence when it came out suggested that there was going to be a reduction in opioid use for the state with the medical marijuana that had been passed. Further studies show possibly no effect on opioid use for the community at large. So that may not be a legitimate bit of evidence there. But that's the point of evidence-based medicine, is we have to keep testing it in order to refine the evidence. And then, as I mentioned earlier, standardized reporting and training by and for the county coroners was another legislative issue that was addressed to give us better data. Prevention, the key players there is everybody. We looked to increase our number of amnesty boxes. That was a law enforcement issue. You can't really put amnesty boxes not located with law enforcement because of the possibility of someone trying to break into them. There's been reports of people, hooking a toe strap to one and yanking it out of the wall, that sort of thing. Take back days, there's usually 2 a year. We've tried to get 3 to 4 a year going. And that's a law enforcement and community leadership issue. And that's been effective as well. We've taken, I've got a slide for you here in a second. Arkansas on its own does a very good job with drug take back days compared to other states around us. School interventions, we've got school district and outside organizations that are engaged in that as well. The PDMP, again, for prevention, medical and dental providers. And then what we've kind of tried to set up here is a community standard for prescribing, which is 3 doses a day for 3 days for acute pain. So you have a kidney stone, you break your ankle, you've got surgical pain, 3 doses a day for 3 days for acute pain. There is a study that was done, I think at UAMS actually, that looked at your opioid use disorder at 1 year compared to more or less than 3 days of narcotic. And if you go past 3 days, your opioid use disorder goes up significantly at a year, as opposed to just doing that first 3 days. So that's education provided by myself, the county health officer, the medical society, and the medical board. And we're also trying to raise public awareness as well. There were some at the time we had some pamphlets that were coming from UAMS regarding what to expect from your surgery and what to expect for your pain management after your surgery. And one of the things that was specifically addressed in that was prevention of opioid use disorder down the line for someone who's having acute pain that was being treated appropriately. Having done this for 20 years, I've seen the pendulum swing both ways. We went from pain is the 5th vital sign and was your pain adequately treated on your HCAP survey for the hospital, where we started over treating it in order to try and improve our patient satisfaction rates, to the exact opposite, to where we're not treating appropriately very painful conditions. And remember, you go to the doctor because something hurts usually. That's why we go. So that's the public awareness part of that as well, to try and manage expectations. There's the National Drug Take Back Day, the regional results for DEA. The great big blue line in the back is Arkansas, and I'm pretty proud of that actually. When you look at how many pounds that we collect, it's just astounding. 24,000 pounds, in a month, and that was October of 2022. I'm sorry, 21. But you can see how we compare to Louisiana, Mississippi, and Alabama, similar states in demographics, similar states in population. Arkansas, 3 million at that time, Mississippi, 2.9 million, Louisiana was 4.6, and Alabama, 5 million. And even as the third most popular state in this particular list, we were clearly the #1 collector of unused prescriptions. Now, I will tell you that a good number of those prescriptions that are collected are not narcotics. They are other medications. However, from an environmental standpoint, that's not a bad thing either, because what do most people think about doing when they have an unused prescription that they want to dispose of? Well, they drop it down the toilet. Of course, this can contaminate groundwater with all sorts of things. There's measurable levels of SSRIs and hormones in a lot of the sewage effluent in large cities, and that's been measured and reported in the environmental literature, and it's kind of interesting. So this is a way to help address that as well as a secondary effect from the opioid interdiction that we're trying to do with the take back days. So that's the Arkansas Take Back. And they do have a website if you're interested in looking at that. That's artakeback.org. And there's other things you can get as well. Like there's pharmacies will have kits that you can do a disposal kit for and that sort of thing. So education, again, everyone, for the community, we're looking at advertising, health fairs, opioid summits. Patients, I mentioned already the UAMS What to Expect from Surgery pamphlet that we had deployed for about 1.5 years or so. Children's programs in an effort to educate, elementary and middle school age children. Educational activities for our physicians and providers. And then basically our sheriff functioned as our public information officer to help raise awareness with regular interactions with the media, generate consistent messages and talking points for committee members. So we were all kind of on the same, on the same message, so to speak. As far as emergency care, the key players there, everyone, hospitals are working specifically lately, looking at electronic prescribing with 2-factor authentication for our opioids within the hospitals, when someone's being discharged. That's been a big one. I know Mercy struggled with that a little bit. I think Baptist has that under control at the moment over here. I know UAMS has been ahead of that, being centrally located. Educating our emergency room physicians to not refill long-term medications out of the ER and to treat acute pain appropriately. EMS, as far as emergency care, working on response times of the Don't Run, Call 911 campaign, and also getting Narcan into the community. One of the things we ran into is we got this huge bolus of Narcan kits for our law enforcement community, and then they start expiring after a while. And so we've started we're working on rotating that stock with the short dated stock with our EMS providers in order to get updated stock for our law enforcement community. EMS goes through it a lot quicker than law enforcement does. And then the community at large. One thing I'm looking at trying to get going next would be getting Narcan co-located with AEDs in places like churches and the mall and whatnot. Of course, our sheriff said, well, what if someone steals it? And I was like, well, then they probably needed it. So that's kind of the goal. I mean, you change your mind a little bit, your mindset a little bit when you start looking at public health, because the public is your patient at that point in time. We had similar issues when COVID started, where we had patients that were absconding with masks and gloves. And that was frustrating because we needed the masks and gloves, but at the same time, you're looking at people that were preventing spread. So it wasn't necessarily a bad thing. It was frustrating, but it wasn't a bad thing because it was helping the community health overall. So, but that's one of the initiatives I'm trying to get worked up right now, is getting Narcan co-located with AEDs. Law enforcement, here we're dealing with law enforcement, legislators, judges, correctional facilities. I mentioned the heroin interdiction, now fentanyl. Diversion, where we're trying to get a DEA representative added to our task force. That hasn't really materialized, but it's there. As far as state medical board actions, that's another issue we've interfaced with a little bit. We do have the luxury of having a state medical board member here in Arkansas that's located at the Mercy campus, and then I believe our DIO, I heard the rumor, is also a member of the state medical board as well. So I will probably be tapping her at some point for that as well. The Narcan program, we got that done. We expanded that into schools with the school resource officers and also the school nurses, and got them trained up, and kits deployed for them as well. Drug court, I mentioned, reduces our recidivism significantly. And these are people that are brought in periodically for drug testing and to appear before the judge. And basically they're held accountable for their actions. And so rather than going to prison for a drug offense, they get an alternative sentence to the drug court, where they get probation on steroids, where they are monitored super closely and given specific tasks to accomplish and goals, and then they have a big graduation from it when they get out of the drug court, and it's been a good thing overall. As far as treatment, that's medical in the community. At the time, we were trying to encourage local providers to obtain their Suboxone certification for DEAX and train local residents for DEAX. As far as our behavioral health curriculum at our campus, the DEAX medication-assisted therapy training is part of that curriculum for our residents. Even though it's no longer required for prescribers, it's still a good idea to get that training, just so you have the academic basis for what you're prescribing. We had a pilot project here at our clinic for Suboxone and MAT that was derailed specifically by COVID, and we're trying to get back on track for that. And then we also had a partnership with the Matriarch program through that, and that was been run mostly by one of my partners, Dr. John Lane. And we're still working on increasing and improving that access to the community. This was just how we felt with the COVID stuff. Every time we thought we got ahead of it, we got hit again. So here's our data for waived practitioners by county as of 4/21/2022. It's hard to see, but Sebastian County now has one of the highest numbers of prescribers for DEAX providers. When we started off in 2018, I think it was like 4, and now we're up to like 63, 73, something like that, in that range. And you can see a lot of other our major population centers like Craighead County, Pulaski County, Washington County, Sebastian County, all have upped their number of waived providers significantly. So that's something we've done right as far as the treatment aspect. So this was 2017, 2018 data. This is our recipients seeing 5 or more physicians and 5 or more pharmacies in a 90-day period in Arkansas. And 2017, we were looking at, we had 300 that were identified in Q1. PD&P law went into effect, and then by Q4 of 2018, we were down to 61. So that's what I was talking about as far as the PDMP having such a striking impact on things. We saw something similar with the methamphetamine issues in Arkansas when we started requiring a state driver's license and they had to register with a pharmacy in order to buy pseudoephedrine. And the number of people that were cooking at home dropped significantly just because of that one obstacle that was put there. As far as our total morphine milligram equivalents, this is what we're seeing in the community in Arkansas. This is from 2014 to 2018. We went from a peak of about 3.2 million morphine milligram equivalents for the entire state down to 2.1 million. So that was a success there. Again, that's with the PDMP effect. We did have an increase in our overdose deaths in Sebastian County, even after we started all this effort. But again, I think that was reporting changes, and also we were looking for it. And when you start educating the community, they're going to be more adept at identifying things. And so, deaths were attributed more appropriately, especially coming through the ERs. So instead of it being a sudden cardiac death, the appropriate testing was done, and now it's a fentanyl overdose or an opioid overdose. So again, from the PDMP, these are our chronic opioid users in Arkansas prescribed by Arkansas prescribers. And we peaked again right about December 2016 and have slowly started coming down. So as far as a summary of our successes from that 4-year period, we had increased availability of MAT, a decrease from 102.1 to 71.7 prescriptions per 100 persons, from parity with the state average to below the state average, increase in naloxone use by law enforcement and the lay public, increase in number of take-back days and pounds of pharmaceuticals removed from circulation, decrease in recidivism for persons who successfully complete drug court, and decrease in number of NAS babies treated. So what's the recipe? It starts with a leader with authority who can command, has command of some local contacts, both political and social, as well as in the media. In our case, that was our local sheriff, but that could be a mayor, that could be a county judge, it could be, anyone like that. And then the number 2 thing there is a busybody. We need a busybody because all these people are busy and it's hard to get them all in the same room. We're going to come back to her in a second. You need a subject matter expert. That gets to be me. We've got recovery service providers. Those are our treatment centers that participate in the task force. We have a school system representative, community representative, law enforcement. You need a local pharmacist that can kind of keep their finger on the pulse of prescribing habits in the community. You need hospital representatives so that they have buy-in as well. EMS, we had a legislator for a while who was also a pharmacist, so that was pretty handy. Addicts, former and otherwise, because you need their input. These are the people you're trying to help. You need these people that have been diagnosed with opioid use disorder, and especially those that have recovered and been clean for a while, because they're very important for the peer recovery process. Especially, we have a peer recovery process we're using in the jail in an effort to try and start treating this early rather than just punish it. And then our elected leaders. And as I mentioned earlier, this should be a problem without politics. And I was very pleased to see the transition of power between 2 parties and have it not impact this at all. And the sheriff likes this because it reduces crowding in his jail. So this is our busybody. This is Pat Morris. She's the Mercy Health Systems librarian for Fort Smith. She's also a grant writer. As I said, she always has coffee at meetings for participants, and she's not afraid of anything or anybody. And I won't give her my phone number for reasons, but she can email me. But she makes sure that the room's scheduled. She pesters everybody to be there. She sends all the minutes out afterwards. She is the driving force behind everything. So that's one of the more important key parts of this recipe is getting someone who's going to be able to do that. Someone with an activist mentality who's got the time to spend on it. Because none of us on the task force have that kind of time. We're all busy with our real jobs. This is her real job, so it works out. So what to do? If you want to build something like this in your community, how are you going to do it? You want to start with your low-hanging fruit first, and some of that's just identifying your low-hanging fruit. The DJI grant for Narcan is a good start. There's other grants that are available as well that kind of come and go between for the different years. Getting Narcan into the schools and the school nurses trained up for that. That's an easy one to do as well. The Don't Run, Call 911 campaign, just educating the population about that law so that you have faster response times to your opioid overdoses in the community. Drug take back days, that's going to be a law enforcement issue, but again, that's an easy thing to organize. So they already do it twice a year. You can probably get a third or fourth day a year if you really work at it, and then you advertise for it. Physician education, again, grand rounds. That's another one that's pretty easy to do. The resources are out there for as far as the statistics and the training, and it's really easy to redeploy that to your local prescribing community. Secondary goals, which take a little bit more effort, alternative sentencing and drug courts, those have to be established and paid for somehow. And so that can sometimes be a bit of a sell to your local power structure. Setting up a local summit, you need to find a place to do it. You need to have an agenda. You need to know who your speakers are going to be. DEAX providers, again, that's been waived, so that makes life a lot easier there. But that could actually probably be moved to the low-hanging fruit area. It's real easy to get that and start doing it. Which will then improve your access to MAT programs. Lofty goals, what would we like to see down the line? We'd like to establish better treatment centers. We'd like to open MAT dedicated clinics. We'd like to see harm reduction in the form of HIV, hepatitis, and staph, as far as how it impacts our patient populations. And then what other legislative interventions could there be? For example, needle exchange programs. And the goal overall is going to be to improve the quality of life in your community. You want a healthier population, a more productive population, and you want to have less property and personal crime. And this is really something I believe here. No single raindrop believes it's responsible for the flood. You have to get a bunch of people together and have them share information, and then things will start to work. No one person's going to be able to do it by themselves. So it's a community effort. And so finding like-minded people in the community is probably your most important thing to do. This is just notes from our recent activities, just to kind of give you an idea of the things we've been up to. This is for the month of July, and I've got an updated agenda from February I'll go over with you as well. Our Harbor House Region 6 conference was coming up. September was Recovery Month. October was a drug take back day that we got scheduled. They reported that the fentanyl use was on the rise. Meth was still a big use issue. Portsmouth Public Schools reported they had a drug prevention education at the school wellness center. Restore Hope / 100 families are kind of combined now. We're now in 6 counties and trying to expand, and they were doing coordinated help for treatment, housing, and other areas of need. And they were hosting a meeting of district judges in October. Kathy Wilson, one of our local members, managed to get a Narcan grant and educated 12 caseworkers, distributed 70 kits to mental health providers. Got a grant from a local church to provide training in Sebastian County. Did note that their treatment center was having issues with no-shows, which is not surprising. Mercy reviewed their community needs assessment, and they've got an outpost in Logan County, and they had community concerns there regarding opioids and mental health. And Mercy is required to complete a community needs assessment for the service area, and I suspect Baptist does as well up here. Anyway, he reviewed that. The social workers from Mercy then were working with providing assistance with applying for insurance, assistance, housing, utility needs in the Mercy service area. The Mercy ER nursing reported that local physicians had reduced prescribing habits. Some was still making it to the streets, and illegal drugs seem to be on the rise. Again, that's that fentanyl replacement problem that we talked about earlier. We had reached out to Logan County for technical needs and starting a task force as well. Sheriff Runyon had reached out to Logan County to offer assistance. The Logan County Sheriff had outlined some programs local to their county. They'd started a peer recovery program in their jail. They started a GED program in their jail, and they were working with the Guidance Center, which is our local psychiatric provider for mental health programs in the jail. And then they talked about the needs for the rest of the county. They actually elected to partner with the Paris Health Council rather than developing a task force similar to Sebastian County, which is fine. Because here's one of the caveats, and those of us that do disaster stuff will tell you that all responses are local. And this is one of those issues here. The response should be tailored to both the community resources and needs. Not every program is going to look like ours, and nor should it. And before I jump into questions, just kind of go over some of the stuff recently that's happened. In February, we have an upcoming summit that's going to be both virtual and live. That's going to be April 28th, and we're going to have Kirk Lanes coming for that as well. And we have a personal story, one of our recovery experts who has been through addiction and has a story to tell. I'll be updating on fentanyl as well. We're going to have the National Network of Libraries of Medicine for Region 3 will be presenting as well. So those are some things we'll be working on there. And then I think it's April 5th, I'll be doing the community education for Mercy for Grand Rounds in order to update a number of prescribers on the current opioid guidelines, since there've been some minor changes from CDC this year. We'll be updating that, and that'll satisfy that 1 hour of education that's required. And that will be attended by all 3 residencies here local as well. So those are some of our educational activities that are coming up. So this is kind of the overview of what we've been doing. And like I said initially, this is largely an effort to share information. And that's where we find the most value in our activities is one person has a problem, another person has a solution. And if they weren't in the same room, they would never know that. And that's kind of how we've been working on things. Good example, how do we get this Don't Run, Call 911 campaign into the schools? Well, the school representative popped up and said, well, we can just put those in the bathrooms. That's easy. Okay, here are the flyers. And then they did it. And, that's the kind of thing that needs to happen. Whereas otherwise you wouldn't really, you'd spend a lot of time trying to figure out how to deploy that resource. So I'm happy to take any questions about what we've done and what we've accomplished. And I'm also more than happy to get anyone who's interested in participating or starting a task force in their area, the technical assistance from our group, just so you don't have to reinvent the wheel. So if anyone has any desires on that, just send me an email address and we'll get you in touch with Pat, our busybody. So my first question, is there a list of groups, coalitions, so that if people in different areas of the state want to be involved, could get involved in their area? Not specifically, and not easily. It's one of those things that gets developed in those communities specifically. Usually any of your local social workers who are doing anything with addiction recovery can be of help. And developing those lists. But that's actually one of those things we had to do as a task force, was develop those lists. One of the things that we put together about 2 years ago was a reentry handbook for people that were coming out of the penal system to try and get them into, back into a stable situation, and or just people that were in recovery to try and get them in a stable situation. And it's basically a book that tells them, here's where to go to get a copy of your birth certificate. Here's where to go to get a copy of your driver's license. Here's how to get a copy of your social security number. It's like all these documentation that makes you a person in this country. Frequently, these people lose it, and they just have no documentation to accomplish anything. So they can't get a job, they can't get an apartment, they can't, and they fall back into the lifestyle they were in. And that booklet is basically, half of it is just a list of community resources. And I can certainly see about sharing that, but that's going to be local to us. And it might be more of a matter of just taking a list of possibilities and seeing what's in your area. I wish I had a better answer for that. All right, so here's a question. There are thousands of providers in Arkansas. Would you be willing to speculate as to why we only have 74 DEAX certified providers? That's 74 in my county. I know the Matriarch program has been working for several years to raise this number from 4 to 74. Could some providers be hesitant to have those kind of patients in their practice, and how would I address that? Well, I would actually say that those providers already have those kind of patients in their practices. They just haven't identified them yet. So they're already there, right? That as far as that's concerned. And the number I quoted was we went from 4 in my county to 74. And I don't have thousands of providers in my county. I've got about 900, I think, between the 2 hospital systems. So that's gotten a lot better. And the problem we have now is that's the waived providers that we are able to track. Well, now that you no longer need that waiver, that's going to be harder to track. And so now anyone can prescribe. I kind of liken this to HIV care. If you remember back in the 80s and 90s, HIV care was relegated to infectious disease specialists in university centers. And now it's a primary care problem. All of us in primary care and family medicine, we have HIV patients in our populations that we take care of. And so I see the MAT issue to be a similar thing as far as changing our perspective on how we do things as providers. All right. Let's see. Question: has a test been developed that can determine the presence of fentanyl at the scene of death? Not everyone makes it to an ER for further testing to determine the cause of death. So that's an excellent question. There's actually, you can actually get fentanyl test strips. They're available on Amazon. There's been some argument here lately as to whether or not those should be legal in this state or not, because there are some people that want to consider that to be drug paraphernalia, because are you testing the purity of your product, or are you trying to prevent a death? Most people are trying to prevent a death. So those test strips do exist, though, for sure. And so, yeah, those kits are out there. The test strips you can get like off of Amazon, those are for people that are, worried about their drink being spiked, when they go out or something like that. Or they want to test their drug of choice to make sure it doesn't have fentanyl in it. What we're finding is that a lot of other drugs that are marketed as other things like ecstasy or methamphetamine, or even things like, fake Adderall on the street will frequently have fentanyl in it as well. And so people are wanting to test those. So that's one modality that's out there, but its use in Arkansas is somewhat dubious at the moment in terms of legality. Next question: have we considered inviting veterinarians to our task force? They are also prescriber of opioids. We had not, but maybe we will. I don't know how much diversion happens from the veterinary offices. So, I mean, who do I think is the current group that needs the most education? Physicians, veterinarians, dentists, parents. I would start by saying physicians, because the problem we have is that physicians are frequently the gateway to opioid use disorder and people getting into some of the harder drugs. So that's probably the group that needs the most education, is going to be physicians, followed closely by dentists. I think we're probably in the same boat, because we do a lot of prescribing for acute pain. What we need to make sure we do is don't turn it into a chronic prescription. Parents and patients are going to be also people you want to educate as well. It's kind of like trying to convince a parent that their kid doesn't need an antibiotic. It takes a lot of effort. And sometimes it's just easier to do it and not fight, but we can't do that, because then we end up creating a problem that will last, potentially lifelong for that particular patient. So it's a similar process. I think that's all the questions we have. I'd like to thank everybody again for listening to me drone on for an hour about something I've been busy doing the last 5 years. And again, I welcome any other offline questions. And I appreciate everyone's attendance. Thank you very much.